Hello friends, today we will be discussing about the cardiomyopathy in this video and particularly about the dilated cardiomyopathy. So what exactly is the cardiomyopathy? As the name is suggesting, there is some abnormality in the heart muscle. Cardio means heart, myo means the muscle. So this is a heterogeneous group of the diseases where we have abnormality in the myocardium, and that abnormality can be mechanical like in the contraction, or it can be because of the electrical dysfunction. So whether it is mechanical or because of the electrical dysfunction, there will be inappropriate ventricular hypertrophy or dilatation. So all these diseases which have these features, they come under the cardiomyopathy. Now this is basically classified as a primary cardiomyopathy and secondary cardiomyopathy. So here also, as the name suggests, primary means it is involving primarily only the heart muscles. Whereas secondary cardiomyopathy means there is a systemic disorder which is involving multiple organs. Along with that, we have involvement of the heart also. So if it is secondary to certain systemic disorders, we call it as secondary cardiomyopathy. And if it is primarily involving only the heart, we call it as primary cardiomyopathy. Now, depending upon the clinical, functional and pathological patterns, the cardiomyopathy has been classified into three major types. So we have dilated cardiomyopathy, hypertrophic cardiomyopathy and restrictive cardiomyopathy. Dilated cardiomyopathy, as the name suggests, this is a normal heart. If you see, the size of the heart is enlarged. So in the dilated cardiomyopathy, we have a flabby heart, dilated flabby heart, which may have somewhat thinned out walls. In the hypertrophic cardiomyopathy, we have thickened muscle wall. So if you see, there is an irregular thickening of the interventricular septum and also of the left ventricular wall. So this we call it as hypertrophic cardiomyopathy. And in the restrictive cardiomyopathy, the size of the heart remains normal. We have the heart muscle which will be normal, of the normal thickness only, but there is certain deposition in between the heart muscle so that it cannot dilate properly or it cannot contract properly. So that's why they call this one as restrictive cardiomyopathy. Now among these three patterns, the dilated cardiomyopathy is the most common one and the restrictive cardiomyopathy is the less frequent one. Now when we see about the ejection fractions and the mechanism of heart failure in the three cardiomyopathies, in the dilated cardiomyopathy, the ejection fraction will be less than 40%, and the mechanism of heart failure is usually systolic dysfunction. It is a dilated flabby heart, so it cannot contract properly, so there will be a systolic dysfunction. And in the hypertrophic, the left ventricular ejection fraction is 50 to 80%, and here it is the diastolic dysfunction, impairment of the compliance, because the muscle is very much thickened, the volume of the heart chambers is reduced. So there is a diastolic dysfunction. And the restrictive cardiomyopathy, the left ventricular ejection fraction is 45 to 90%, and here also we have a diastolic dysfunction, diastolic, and actually here we have even the systolic dysfunction also. We have a list of the causes. When we are dealing with each one, we will be seeing them. So, okay, we'll see the names of them. In the dilated cardiomyopathy, we have genetic causes, alcoholism, peripartum, myocarditis, hemochromatosis, anemias, doxorubicin, Chagas disease, and most commonest one is idiopathic. Whereas in the hypertrophic cardiomyopathy, the most common is genetic causes. Then we have Friedreich's ataxia, also storage diseases, and this we also see in the infants of the diabetic mother. Whereas the restrictive cardiomyopathy, we see in the amyloidosis, storage disorders, in the radiation-induced fibrosis, and in idiopathic causes also. So coming to the topic proper, that is the dilated cardiomyopathy. So as the name is suggesting, dilated, the heart is dilated. So we have progressive cardiac dilatation and we have a contractile or the systolic dysfunction in this. This is also called as congestive cardiomyopathy. Now what are the causes of this? We have a list of the causes, out of which the idiopathic is the most commonest one. So we have the first cause is the alcohol abuse, alcoholism. Then we have how each one causes, I'll tell you in detail again. Alcohol abuse, then we have Beriberi heart disease and thiamine deficiency. Cobalt poisoning, which if we see because the cobalt is used in the tinting of the beer production. So this cobalt acts as a contaminant, and that poisoning will cause cardiomyopathy. Then we have viral myocarditis. This is because of the Coxsackie B virus infection. Then chronic cocaine use, chemotherapy drugs, Chagas disease, doxorubicin toxicity. We have a genetic causes also. Then we have a supraphysiological stress in conditions where we have tachycardia or hyperthyroidism, or in the tumors which are producing epinephrine. So this also causes dilated cardiomyopathy. And another interesting cause is Takotsubo cardiomyopathy. This we see in severe psychological stress. Then another cause is in the iron overload, that is in the hemochromatosis, and also in the pregnancy. Out of all these causes, the idiopathic is the most common one. And a small shortcut to remember this is B-Dic-C past. So C5 past, because we have 5 C's in this: cocaine use, chronic cocaine, chemotherapy, Chagas disease, cobalt poisoning, and Coxsackie B virus. So C5 we have. So B-Dic-C5 past. If you remember this sentence, all the causes of the dilated cardiomyopathy will come in that. So when we see alcoholism, so the alcoholic cardiomyopathy, it can be because of certain genetic factors, or it can be because of the direct toxicity of the alcohol. So in the genetic factors, HLA subtypes, they play a role, and also the differences in the alcohol dehydrogenase enzyme allele. So because of the variation in this alcohol dehydrogenase enzyme, there is differences in the metabolism of the alcohol. So the byproducts which are formed, in some patients, that will be more harmful. And the non-genetic factors is, in the alcoholic patients, they have thiamine deficiency, and also there can be a direct toxicity because of the alcoholism, which causes the mitochondrial damage in the cardiac muscle, so that there will be an oxidative stress injury. And also there is a modification of actin and the myosin structures, and we have alteration of the calcium homeostasis. This is a direct effect of the alcohol on the cardiac muscle. Then the next one is the beriberi, that is a thiamine deficiency. Now this thiamine, it forms a component of thiamine pyrophosphate, which acts as a cofactor for citric acid cycle, and also it is used for the metabolism of the carbohydrates, proteins and fats. So when we have a deficiency of the thiamine, the metabolism of all these things and citric acid cycle is affected. So we have increase in the pyruvates, lactates and adenosine. We have accumulation of these things when we have deficiency of the thiamine. So adenosine, when you have increase in the adenosine levels, there is a vasomotor depression, which leads to decrease in the peripheral vascular resistance. So when there is a decrease in the peripheral vascular resistance, there is a more flow of the blood into the veins, and there is an increased cardiac preload. Not only that, the thiamine deficiency, it directly affects the heart muscle also, because it causes it downregulates the other metabolisms also. So directly the heart muscle is also affected. So myocardial dysfunction along with the increased cardiac preload, it causes the cardiac failure. Now beriberi, they call it as a wet beriberi and dry beriberi. Wet beriberi is a condition where we have right-sided heart failure with pulmonary hypertension and high cardiac output. So when the heart is involved, we call it as a wet beriberi, whereas dry beriberi is when there is a peripheral neuropathy which causes the motor weakness and areflexia. This is because of the decreased production of the neurotransmitters like the GABA and the glutamic acids. Because of this, this is also because of the thiamine deficiency. So if the thiamine deficiency is producing the neuropathy, we call it as a dry beriberi. If it is producing the heart failure affecting the cardiac myocytes, we call it as a wet beriberi. Another one is the cobalt poisoning. Now as I told you, this cobalt is, it becomes in the beer production, it is used, it becomes a contaminant in the beer production actually. So when there is a cobalt poisoning, this cobalt will interrupt with the citric acid cycle, and also there is a decreased generation of the ATPs by the aerobic respiration. So this goes to increased production of the reactive oxygen species, which will cause damage to the cardiomyocytes. Not only that, the cobalt will also interrupt with the binding of the calcium to sarcolemma and also transport of calcium into the myocytes. So that will also cause the dysfunction of the cardiomyocytes. So there is a decrease in the cardiac function and also changes in the cardiac cell structure because of the cobalt poisoning. Then hemochromatosis, which we see in the iron absorption is more. In this condition, we have iron deposition in different organs. So in the heart, initially this occurs in the ventricular myocardium, then it occurs in the atrium, and then in the conduction system. So iron in the myocytes, what does it do is it impairs the calcium transports and impaired excitation, contraction, coupling. Not only that, if you remember the cell injury, iron, if it is freely available, iron molecules are there, they are used up in the Franton's reaction. So because of which there will be increased production of the reactive oxygen species. So this reactive oxygen species again will cause damage to the cardiomyocytes. So because of this, there will be diastolic and ventricular dysfunction in the hemochromatosis. Next one is viral infection. That is the most important one is a Coxsackie virus. Coxsackie B virus, which causes this dilated cardiomyopathy. In this, the viral protease 2A, which is present in this Coxsackie virus, it cleaves the cytoskeletal dystrophin protein. Now when it cleaves this, there is a disruption of dystrophin glycoprotein complex. Now because of this disruption, there is a loss of sarcolemmal integrity and there is an increase in the myocyte permeability. So when this is there is a loss of sarcolemmal integrity, there is a damage to the cardiomyocyte that causes the dilated cardiomyopathy. Now another one is the doxorubicin toxicity. Now in the doxorubicin toxicity, there will be increased reactive oxygen species production, which causes oxidative stress. So this oxidative stress, it induces and activates the P53. So this causes the apoptosis. Not only that, the doxorubicin, it also causes downregulation of actin, myosin light chain and heavy chains, troponin 1 and desmin proteins. Because of the downregulation of these proteins, there is a myofibrillar loss and decrease in the myocardial contractile function. And also there is a downregulation of sarcoplasmic reticular ATPase. This causes abnormal myocardial dysfunction, diastolic function. So all these three things, they cause again the cardiomyopathy because of the doxorubicin toxicity. Then another cause is the Chagas disease. This is mainly caused by Trypanosoma cruzi infection. So because of the infection of this parasite, there will be a widespread immunological reaction involving different organs like heart, GIT, meninges and peripheral nervous system. So we have a deposition of the eosinophils in various organs, and these eosinophils, they will release their basic protein, which will be causing damage to the whichever organ they are present. So in the heart, they cause myocarditis, causing myocyte necrosis, and endocardium, it affects producing endocarditis, and this is one of the major cause for the thrombi formation. Then it also involves the sinus node and conduction system of the heart. Now because of all these conditions, again there will be a dilated cardiomyopathy. And peripartum cardiomyopathy, so the causes are, we have a list of the causes in this. The pregnancy associated hypertension can cause dilated cardiomyopathy, or volume overload, nutritional deficiencies, metabolic derangements, poorly characterized immunological reactions, and elevated levels of anti-angiogenic cleavage products of hormone prolactin. All these things in the peripartum period, they can cause the dilated cardiomyopathy. Now when we see the genetic causes, mutations in the genes which are encoding for the proteins which are present on the membrane, which are present in the cytoskeleton, present in the mitochondria, sarcomeres, nuclear envelope and in the nucleus. So mutations in the genes which are present in this can cause dilated cardiomyopathies. So specifically the genes which are encoding for the desmosomes, for the proteins in the membranes, for the desmosomes and sodium voltage gated channel alpha subunit. So these are present on the membranes. Then when we see in the cytoskeleton, the genes which are encoding for the desmin, dystrophin and delta sarcoglycans. So they also can cause dilated cardiomyopathy. Then the genes which are encoding for in the sarcomere, which are encoding for alpha cardiac actin, beta myosin heavy chain, cardiac troponin C, cardiac troponin 3, cardiac troponin I, tropomyosin and titin. So the genes which are encoding this, if there is any mutation, that also can cause dilated cardiomyopathy. And in the mitochondria we have two proteins, that is tafazine and C19 heat shock protein. So genes undergoing mutations which are encoding these proteins, they also can cause. Then the genes encoding nuclear envelope proteins like amirin, laminin A by C, and in the nucleus RNA binding protein 20. So all these genes, any of the genes, if they undergo the mutations, they can cause the dilated cardiomyopathy. And another interesting one is Takotsubo cardiomyopathy. This is also called as a heartbroken syndrome, usually which occurs in increased psychological stress. If you have a loss of your loved ones or a severe psychological stress, suddenly there is a dilatation of the left ventricle. The apex, at the apex there is an apical ballooning that resembles Takotsubo. Now Takotsubo is a fishing pot used in the Japan for trapping the octopus. So it looks like this. So this is a Japanese pot which they used to trap the octopus. So our heart also becomes like that if we have a severe psychological stress. There is an apical ballooning. So this one they called it as a Takotsubo cardiomyopathy. Now when we see the morphology, that was all the causes what we have seen. When we see the morphology of the dilated cardiomyopathy of the heart, so heart is completely dilated and it is flabby, and because of the dilatation of the chambers, even the valves cannot close properly, so there can be the regurgitation. So patient can have tricuspid regurgitation and the mitral regurgitation. And because of the stasis of the blood, because the contraction is not normal, there can be a stasis producing the mural thrombi. Now when we see the myocardiocyte, what is the change in that is the length of the myocardiocyte will increase because the sarcomeres present in the myocytes, they are increased in the series. Instead of increasing in the thickness, they increase in the series so that the length of the myocardiocyte is increased. And histologically when we see, we have the muscle cardiomyocytes which are stretched. But later on, because the systolic function is not normal, in order to compensate that, the heart tries to become hypertrophied. So we can have the muscle cells which are hypertrophied with enlarged nuclei. And typically in the titin gene mutations, the myocytes will have highly distorted star-like, ninja star-like nuclei. Seeing here, the hypertrophied muscle which are having this ninja star-like nuclei. This typically we see in the titin gene mutations. Now when we see the clinical features, fundamental defect is ineffective contraction. It is completely dilated, so the systolic function is not proper. And the age group we see in the elderly, 20 to 50 years of the age group, and the patients will develop the features of the congestive heart failure, which includes dyspnea, easy fatigability and poor exertional capacity. And at the end stage, the ventricular ejection fraction will completely come down and it will become less than 25%. And the patient will have the regurgitations and abnormal cardiac rhythms. And because there is a thrombi, there is a chance for the formation of the emboli also. And the patient will develop peripheral edema due to the further right ventricular dysfunction. And death usually occurs because of the progressive cardiac failure or arrhythmias. Now when we see the summary, we have to remember that what is a definition. Definition of the dilated cardiomyopathy is progressive cardiac dilatation and contractile dysfunction. Then we have a list of the causes, which includes, if you remember this, as I told you, B, Dic, C5 past. So we have alcoholism, which can cause direct toxicity, beriberi, that's a thiamine deficiency. Then we have Chagas disease, Coxsackie virus, cobalt poisoning, chemotherapeutic drugs, cocaine use, doxorubicin. Genetic causes we have, then supraphysiological stress, Takotsubo cardiomyopathy in severe psychological stress, hemochromatosis, and also in the pregnancy. So all these are the causes for this. And morphology, when we see, we have an enlarged flabby heart and we have the cardiomyocytes which are having the sarcomeres which are placed in the series. So the length increases, and muscles, they will be stretched, and sometimes they will be hypertrophied, also having a ninja star-like nuclei. Now clinical features, they will be of congestive heart failure like dyspnea and the fatigue. Patient will have the peripheral edema, thrombi may develop, regurgitation will be present, and the death will occur because of the progressive cardiac failure and the arrhythmias. Thank you, friends. Thank you for listening patiently.